recorded for review later. I see Stephen here. I believe Tricia will join, which would make us quorum. So if somebody can help make sure in the background that Tricia joins at one point, that would be great. I didn't have any actions myself to report on. We received a few apologies. Mark Burgess, Karen Watts, Jason Stokes, Peter Taylor, Ian Wake. As always, at the end of it, we'll double check if that's the full list, but those are the ones we have received so far. The declarations of interest, the register is there for your reference. Just want to check, does anyone need to highlight an interest in view of today's agenda? Not, we'll move swiftly on to review of minutes of the last meeting. With it, you've also seen written questions and answer from around Toftwood, so those are for your reference there as well. Any comments as to accuracy of the minutes of the last meeting? No, many thanks, Sarah. The action log. Let's see if it's here to hand. With me. So I think that has been dealt with. So that is easy. That takes us to the forward planner. Sadie, you want to introduce that?
Thank you, Hein. I don't have sorry, I'm just scrolling through minutes really quickly. Apologies. I think you can see the red highlighted yeses there of the things that are on the forward planner but are not coming today. I think just for sort of general awareness, that's partly down to the fact that we had an incredibly full agenda today, so had to manage the priority of items, and also partly due to the fact that we're towards the end of the year now, and a lot's changed since this was first drafted. So we are working on the forward plan for 2025-26, and we will present that for approval at the first committee meeting of the new financial year. And obviously we'll share that for comment offline as well.
Yeah. Good. That seems a very pragmatic approach. Any comments from anyone? Good. That takes us to item 6. We stay with you, Sadie, on the risk register.
Thank you. So you'll see a slightly different format to the report this time. We have now moved over to the new system of in-phase reporting, which the ICB has adopted, and we've had some technical issues in downloading risks from that this month, past the teething problems, I think. So we have tried to provide the summary here. So you've got a picture there of all of the risks, and we have also attached the proposed new risk, which on the basis of the current scoring, if that is approved, would place it on the operational risk register, which would then be monitored through the Dental Services Delivery Group. You'll also see that it's proposed that the medicines risk, number 16, is moved over to being monitored by the Medicines Optimisation Programme Board, which reports into the Commissioning and Performance Committee, because it's already being monitored there following the restructure of the organisation. So that's a proposal from Michael. And obviously we've got colleagues on screen to answer any more detailed questions.
Thanks. Yeah, I have a few questions, but let me check first if others specific question. Ian.
Lovely. Thanks, Hein. Thanks, Sadie. Yeah, really, my question is around the ongoing risk for BORR11 about the resilience of general practice. There have been many discussions around the impact of the NI uplift, national living wage increase, and general practice resilience, but that doesn't seem to be reflected in the scores attributed to the risk under that measure. We've stayed static for the last 12 months. Just wondered if someone can explain why that is not actually increasing at this stage, given all we know about the ongoing pressures for general practice from April this year onwards.
Thank you, Ian. And I might invite Hein, if that's okay, James, to talk a little bit about this, because as members will know, we had a letter before Christmas from the Secretary of State advising of an uplift, but how that actually translates into our budgets is still as yet unclear. James, you were probably going to cover this under the finance report as well. So is there anything you can say in relation to the risk?
Of course, no, absolutely fine. So there is a bit of a disparity at the moment in terms of the knowledge that we have from our published allocation uplift. So what we've been told by NHS England is our value, and the letter that was sent out, you're absolutely right, which had a higher figure in it. The current information we've got from national colleagues is that there's still negotiation happening at the moment, and that there is potential for additional allocations to come. They haven't said when or to a value to that, so unfortunately that doesn't give us a satisfactory answer at the moment, but does give us the hope that there will be some additional allocation to cover those. Certainly that is what the Secretary of State letter inferred in there, and had a value against it, which has not been reflected in our current allocation uplifts.
So maybe, because I can see where Ian is coming from, maybe we take an action for the team to review this risk in the light of the latest updates, and the next meeting is mid-May, so hopefully we have more clarity then, and then we can take a view. I don't propose to change the risk yet. I know there's also a new contract, so maybe the totality of those insights can help inform whether 16 is still the right rating. I see a few more hands up. Shepard first, then Lisa.
Thank you, Hein. Just to add on to James and Sadie's points, I've had discussions with a number of practices to understand their understanding of the risks, and they're still working through the impact, or the position is not quite clear yet to be able to be clear about the level of risk that we are talking about and how we can mitigate it. But certainly, in general, the view is there is a risk, but it's not fully understood. So hopefully when we have got a better understanding from the conversations, we should be able to add that at the right time.
Okay, thank you. Lisa?
Thank you, Hein. Further to what you've just said, Shepard, we also need to consider that practices are feeding into us at the LMC all the while. And one of the things that is very worrying at the moment is that the patient demand is far outstripping capacity, and it's impacting staff health and well-being, and that risk is increasing week on week at the moment. So if that could be considered when you are looking at the risk as well, because staff health and well-being is a major concern at this time.
Thank you, Lisa. And in part two, we'll have an opportunity to sort of dive a bit deeper into resilience. So we'll definitely circle back to that point as well. I had a couple of questions. So on the practical stuff, happy for risk ORR 16 to move to another committee. I wanted to ask about BORR RR27, resilience of community pharmacy, because I don't think in this committee we have really considered it in the round, and it has a similar risk rating as general practice, which we're more familiar with, having discussed it many times in this committee. So, Sharon, would you mind explaining a bit more what's behind the risk and what are some of the key actions to help reduce the net risk, so to speak?
Yeah, absolutely, Hein. So I think it was important to recognise formally within the ICB that the risk for community pharmacy. So it's important to recognise that for community pharmacy is funded slightly or significantly different from other providers, with no support for estates, IT or training. So although some of the generic financial issues that have just been raised there remain the same for the rest of the primary care, pharmacy has its own unique challenges in adapting to change for the future. It should be noted that there's still no confirmation of the new contract for pharmacy. It still remains under negotiation, and that is the contract for the current financial year of 24-25 and the coming year of 25-26, which really does hamper the ability for us as a system, or even for our providers, to strategically plan for the future. Due to the flat funding that pharmacies have received over the last 5 years, financial viability remains one of the main drivers for the risk. If this cannot be supported, there is a potential risk for more pharmacy closures. This in turn would potentially decrease accessibility for patients, but potentially will impact the ability for the remaining pharmacies to provide the enhanced services such as Pharmacy First, due to demand dispensing being increased. Remuneration for medicines and also the consistent increase in the medicine supply shortages does mean that pharmacy continues with the challenges of dispensing at loss, which we hear is becoming more and more commonplace. Due to the uncertainty of the future, there was a poll back in November 2024 of the National Pharmaceutical Association members around the potential for collective action, and there was an overwhelming support for this course of action, which I think will be the first time in community pharmacy history. Although no action has been decided as of yet, as they wait for the outcome of the contractual negotiations. If that was to happen, we could potentially look at a potential reduction in opening hours of pharmacies back down to their core opening hours, and also reduction in service provision, such as delivery services, and potentially some of our locally commissioned services, such as our sexual health services. As an ICB, we've been able to mitigate the risk slightly against the opening, because we've been able to review what that would look like for us as an ICB, and there's not potentially much of a risk there. However, we can't mitigate the service risk because we don't know what that looks like. We don't know which pharmacies will stop what services, so that would have to be a reactive look at when we get there. I think community pharmacy workforce still remains unstable, with high vacancy rates for both pharmacists and technicians, and we have a low week time equivalent comparison to other areas in England. Community pharmacy, as we know, has been tasked with the provision of more clinical services, which will require workforce transformation. And I think this is complicated by economic pressures and uncertainty for providers, and also with a lack of funding support from NHS England into our training hub, plus no protected learning time for our professionals. It does mean that potentially that model is not sustainable in getting fit for the future. So as an ICB, we continue to look at our long-term development of our strategy, and the one thing I want to be able to do is to support our contractors to be fit for the future. And that might be actually moving away from a model of just commissioning services. Is there a possibility for us to be able to support our providers with some finances around being able to get their businesses fit to provide these clinical services, which may look at like investing in technology or IT technology to help support dispensing, also potentially the addition of additional consultation room spaces which are fit for purpose to enable them to maximise on the clinical services that are available for them. So that's what we continue to do. We continue to work with our estates team to see if there's things like such as Section 106 funding that we can possibly access for our pharmacies to support them in a slightly different way. But it's important, as I say, for us to recognise the risk, and we continue to work with the contractors and the LPC to try and mitigate as much as possible. I think until the pharmacy contract is confirmed and until we understand what collective action will look like, I think the risk needs to remain the same. But obviously, with the information that may come through from the contract, we will review the risk at that point.
Yeah, extremely helpful. Many thanks, Sharon. The last point was around special care dental services risk to be included, and at the same time there is a proposed reduction in the mitigated risk score. Fiona, could you explain perhaps why the reduction, or what drives the reduction in the mitigated risk, please?
Yes, thank you. So this is a new risk, and it was first presented to our delivery group earlier this year, and hence the reason you can see two actions there. The special care dental services, or more commonly known as community dental services, is obviously a critical part of the primary and community care dental pathway for which we're responsible alongside secondary care. And we already have risks in place for primary and secondary care, and we felt it was important to recognise the risks around special care dental services, particularly as they see and treat and care for our most vulnerable children and adults. So when we first pulled the risks together, we rated it highly. But then you will see from the report that a number of actions are starting to be taken. So we have taken, or proposing, to lower the risk to 12. But of course, workforce, as it does across the whole of primary care dental services, is a key risk. And if the actions aren't taken, then that risk may go up. So that's how we've arrived at the position you see today.
Okay, I'm fine to take the risk as proposed. I think the rule is if the score drops below 15, it comes goes on the operational risk register. So I think that was one of the queries. So I'd like to suggest that if there's a reason to increase the risk, we'll see it sort of raise the profile. If that's okay, Fiona. Good. Any other comments or questions? Good discussion on risk. So many thanks for that. Then we go to item 7, the strategic digital report. And I see Anne has joined us. Welcome. And you can assume your paper has been read, but grateful if you can pick out the highlights, and then we'll open up for questions and comments.
Thank you, Hein, and hello, everybody. Yes, we're particularly pleased that the infrastructure upgrade programme is coming to a close now, and all the practices will have Wi-Fi, which is the last component of that programme that will be live in all GP practice sites by the end of March, and practices are already seeing benefits in improved speeds, but also an ease of working between sites as laptops and mobile devices are connecting seamlessly, and the use of mobile devices within practices is more reliable and bringing more opportunities. We'll also be closing the cloud telephony project at the end of March, and as in almost every area of the NHS, AI and how AI can be used to improve productivity is a big issue in primary care, and we are looking at several projects to potentially start, and we'll be setting up a governance committee to consider all the issues related to the use of AI in the clinical environment.
Mm-hmm. Good, thanks. And I always find these most interesting notes. in terms of new developments and how we become even more digital. So, as you know, I'm particularly interested in the NHS app, and the government has been quite vocal up to the Prime Minister around increased functionality, both in secondary care but also in primary care. So could you share sort of what's on the horizon for the greater public coming year?
Yes, so we have 58% of patients, residents now on the NHS app, and you know, we would like to find a way to encourage the those other 42% to use the NHS app. Healthwatch have been doing a fantastic job in engaging with different populations, so populations like you know, younger people that may not necessarily use their GP practice as much. Looking at the roadmap for the NHS app, there's a lot of focus on integrating secondary care functions into the app. So the patient engagement portals, for example, and the ability to book follow-up appointments in secondary care. The functionality in primary care, you know, it is really great. I love using it. You know, you get your GP consultations in there, any results of tests and things, and we are planning an engagement campaign with the public as well about how they can use it when they're talking to health professionals. So, you know, to share information on medications and things if the health professional isn't accessing another type of system. Another development is around the digital barcode for prescriptions that people will be able to take into a pharmacy and have it scanned to have a prescription issued as well. But yeah, patient-initiated follow-up is the sort of next big thing, and expanding the capability for secondary care integration.
Thanks, Anne. Any other questions or comments for Anne? I'll throw one more in, Anne, if that's all right. And notes digitization, which is another thing that jumped off the page for me. So is it like a pilot project we're doing with NHS England, or can you say a bit more about it?
Yes, so there's a new facility with NHS England, so a new way of digitising notes, which is really good development from the previous plan. So what happened previously was that notes were digitised and loaded to the clinical record. But then as patients moved around, practices would end up building up a library of paper notes again, because not every practice was digitised, and some of the very early adopters have full notes rooms again, you know, having been through it. So what they're doing now is they're having a national document repository, known as the NDR, because we love a three-letter acronym in the NHS. And as patients move practice, or as babies are born, their record will be digital right from the start, and paper records won't be moved to the new practice, they'll be digitised instead. So then at the new GP practice, they will log in to the National Document Repository and they can access the patient's record from there. They can download it and attach it to the GP clinical system. So in that way, there are no more paper records moving around. So Norfolk and Waveney was chosen as a pilot for this work because we have various types of note digitisation. So we've done some work to digitise notes in the traditional way and have them attached to the patient record in the clinical system. We've digitised notes and we have them on a secure SharePoint site, and we've digitised notes and we have them on hosted sites as well. So they are working with us, the NHS England project, to look at the various ways that we might get all of those notes onto the National Document Repository and make them available to wherever the patient moves. So we're hoping to use some end of year funds to help digitize a few more practices as well. it is a big ticket item, if you like, for GP practices, because there's so much space taken with the paper notes.
Yeah. Thanks, Anne. I see no further hands up, so many thanks for the update and the good work you and your team are doing. So many thanks for joining.
Lovely. Thank you. Nice to see you all.
That means we can go to item 8. I see Jade has joined us. Welcome, Jade. And again, well done to the primary care workforce team with the High Commendation Award from the HSJ. So kudos to you and the team. Yeah, if you can take us to the main points of your excellent note, and then we'll open up for questions and comments.
Brilliant. Thank you, Han. Welcome. Good afternoon, everyone. So yeah, hopefully I take the report has been read, but effectively it provides you with a strategic overview really of our journey throughout the last 12 months and also the operational delivery that the primary care workforce team has delivered in line with our strategic ambitions. It's with a really clear focus for a system-wide approach in our workforce planning process, real emphasis on our business intelligence modelling, expanding our learning organisations across the system and also our educators, utilising AI software in terms of our vacancy levels across the system within primary care, and also supporting the rollout and expansion of our coastal and rural programs. Not to mention, we've obviously been delivering general practice and primary care network workforce programs for a number of years, but this year we've had also a focus with optometry workforce and dental workforce programs. So that hopefully gives you an overview of our focused activities for this year. The report obviously outlines both the operational but also the strategic delivery.
Thanks, Jade. There's so much in this note. I could go take a half an hour and query lots of things. Let me see if colleagues have questions or comments. Lisa.
Thank you, Jade. It is a very good report. I've just got a couple of points I'd like to note. You said about the use of AI software. Our concern is that there is a lot of vacancies that nobody can see because they're not being advertised, but they are actual vacancies because practices are unable to recruit due to the financial restrictions. So obviously this is data that is not being captured anywhere that nobody is aware of. We are getting reports from the practices almost on a weekly basis that they've got vacancies that they need to recruit to, but they just can't, especially with the unknowns around NI, etc. at the moment. So obviously there's a big gap in that respect. Whilst we acknowledge there's a lot of good work that's being done around health and well-being, we feel this is not enough. Practices are struggling. We are now getting reports that staff are going on long-term sick with stress and burnout because they can't cope, and there is huge resilience issues within general practice at the present time. Thank you.
Thanks, Lisa. Anything you want to comment at this point, Jade, on it?
Yeah, so absolutely. The AI mapping will only pick up vacancies that are advertised because obviously that's the data that's being pulled. We can't quantify vacancies that are not advertised through recruitment companies or externals. So you're absolutely right, Lisa. We can't report that because there isn't any data to pull from. But I would encourage obviously all practices to utilise our support and offers. As you can see in the report, not every practice is taking up all of our workforce programs, which includes health and wellbeing programs in there. Only 79% of practices within general practice are actually utilising the support that we're offering out. So again, I would encourage all practices to take up those programs, and we will continue to review what we are offering out to practices based on the feedback based from the local intelligence, and obviously that will help inform our planning cycle for 25-26.
I had a detailed question, but there's reference to this workforce planning tool in your note. Jade, could you say a bit more into who is it, who can use it? What is the functionality that really drives the revolution you were talking about?
Yeah, absolutely. So this has been co-designed with practices, directly with practices, initially within general practice, but the tool is flexible that can be applied to any primary care setting. So it's really looking at, as you would expect, looking at their current workforce profile, looking at the future profile of obviously staff retirement, vacancy levels, looking at the 5-year picture for their practice to make sure, obviously, to look at that in terms of our recruitment and our planning cycle. So it is a tool that each practice can use to help them and their business model in terms of what workforce programs and staffing measures they would need to put in place. As I said, we have adapted it. We've worked with practices to deliver that, and it's been very successful in its rollout. So particularly if they're looking at their future recruitment intentions, they'll be utilising that as their starting point, and then they'll work with us to see how we can support them with their delivery.
And an estimate, roughly how many practices are using this presently? Don't need an exact number, but you may have a rough idea.
Yeah, we're around about 40% at this moment using the tool, but we are encouraging all primary care networks to use it, and it's rolling out. So obviously it's fairly new within what we've delivered within this year, but so we expect that going forward that the utilisation of the tool will be enhanced. It's also been noticed at an East of England and a regional level that what we've been working on. So they are again looking to adopt the model that we've approached within Norfolk and Waveney across the system, which is one of our key ambitions to make sure that we're utilising and sharing best practice as we can.
Yep. Thanks. Nick.
Yes. Hello, Jade. Nice to see you again. Jade, I suppose my question was really related to how are the workforce team looking at the prospective dental school in Norwich, because that's going to really closely tie in with the impact that we might have on primary care workforce. Because if the model that they're proposing takes place, and that is that many of the students are trained in their clinical work in general practice under the direction of a supervisor, a clinician within general practice, that's going to impact hugely on the workforce. It's going to impact on the fact that those dentists that are supervising students will need to be much more closely monitoring them than they would do if they were foundation dentists who have already graduated, which means the dentist who is supervising them won't be seeing patients anywhere near as regularly. So that will have an impact. And I wondered, given the fact that on your appendix it looks like the trying to recruit additional foundation training practices hasn't been the greatest of the successes that your workforce team have done. Are we going to really struggle, do you think, to actually find sufficient practices that can help with education going forwards? And I wondered how you are using all of that information to sort of log a potential dental school. And I know we're not at that point where it's got the green light to go ahead, but it's got to be something that we're monitoring, I think, isn't it?
Yeah, thanks, Nick. In terms of the training practices, we haven't been able to deliver what we intended because of the cycle in terms of the NHS dental deanery approves the application process. So we were quite ambitious of trying to get them on board before the year end, but the planning cycle and the approval process happens after year end. So we are currently working with a number of practices now. So then we can obviously report going forward in the new financial year an increase in foundation training practices across the system. So it's just purely timing is one of the reasons why we haven't been able to deliver. But we do know we're working really closely with the deanery in terms of the dental school, looking at foundation placements, and we're looking to develop some new programs within 25 and 26 to help meet that challenge. But you're absolutely right, in terms of dental medical placement provision, that is one of our key priorities, and it will be going forward for 25-26.
Good, many thanks, Jade. If there's no further questions, many thanks, Jade. Excellent note, good discussion. Thanks for joining.
Thank you.
We go to item 9. For those working in the NHS, it's planning season, so this is a very apt note to have in front of us, and I think, Amanda, you will pick out the main points for us.
Thank you. Yes, I think this information was coming here just to let people know that it is the annual operational planning exercise that's being undertaken across the ICB, across all our trust partnerships. It is a huge information gathering exercise, I think, and primary care is a relatively small part in terms of the whole exercise. There was nothing in there that I think came as a surprise. The focus is very much around access and experience for our population, and I think it reflects largely what we've heard locally from our population as well. Nothing will be in the operational plan which isn't already part of other programs. So Pharmacy First, the expansion of unscheduled care for dentistry, they'll all be in long-term plans or PCARP and things. So I think what we're trying to do at the moment is, with the expectation that the document will perhaps remain more live in terms of our conversations with our colleagues at regional and above. So how we monitor that and how we look at that in terms of the interdependencies, I think we have a better understanding of them this year because of the approach that's been taken to the exercise. So it will be looking at understanding those interdependencies, understanding where the risks are and how we mitigate them and how that might change during the course of the year. But we will be looking to tie the reporting of that with other things that come to this committee, such as PCARP, etc. So hopefully that will be a way to keep this group informed of where we are. Yeah, I know in part 2 we have an opportunity to go sort of one level deeper because it's all not finalized yet. So this is a good sort of process update. Very good. Any questions from anyone at this point? No, so I'm sure we'll circle back to committee once the plan is finalized and approved. So many thanks for this update, Amanda. That takes us to the next item 10. I'm not even going to pronounce the medical term, but I'll let Gemma guide us through that. So welcome, Gemma. Can you introduce this note?
Hi everyone. I'm not going to try and pronounce it either, so don't worry. So I'm
so sorry, I've got my hand up.
Hi, Tricia.
Oh,
hello. Can I? Sorry, my lovely Gemma, for interrupting. So, Hein, I'm here because Karen needs to be released to go and do what she's doing. Yeah. I apologise for my lateness, but it had been communicated, Hein.
Okay.
So I'm a little bit surprised at all of the messages and everything that I've been bombarded with. Karen, please feel free to step back. Thank you very much, Hein.
Thank you so much, Tricia, for covering. Thank you. Bye-bye.
Gemma.
Hi everyone. So I'm bringing this paper forward for approval today. So it's to commission a new locally enhanced service to cover HSP monitoring within primary care. So I'll take the paper as read, but I'll just give a brief bit of background and summary. So HSP is an uncommon form of vasculitis, which largely affects children. So it affects approximately around 20 and 100,000. So it is quite small numbers. Children are currently diagnosed in secondary care, and when diagnosed, they require clinical monitoring for 6 months, which involves 4 follow-up appointments. Currently, what's happening is that in some cases, the families are given a letter to take to their GP with instructions about monitoring the child. However, there's been no agreed pathway or funding to support this within primary care. So each hospital had a different pathway with different expectations from their local GPs. So work has already been undertaken by the ICB, and they've worked with the 3 acutes to unify the pathway. So all 3 of them now agree to use the Nottingham Children's Hospital guidance, which is what we've used to base our specification on. So currently practices may not have the expertise or the equipment, so the paediatric PP cuffs that are required to do this work within their core provision, which is why we wish to implement this local enhanced service to help address this. So HSP monitoring has been identified as a clinical priority area by the system interface group. We've also taken the proposal through the prioritisation panel, the quality impacts and the equality and health inequalities impact assessment panels, where we've got approval for these. It's also already gone through our triple lock process. So finances have also been approved to support this service. And we're currently taking it through the provider selection regime process. And we have now finalised the specification, so it is ready to be shared. So if approved, we would look to offer this service out to allow providers to opt in to deliver this service if they wish from the 1st of April this year, 2025.
Many thanks, Gemma. Any questions or comments from colleagues? Ian.
Thanks, Hein. Thank you, Gemma. It's very brief observation or point to be made, which is thanks to everyone at the ICB, Gemma, Janine, and others. Yeah, it's been a bit of toing and froing, but we've got a spec that we're very pleased with. It does what it needs to do. I'm fully supportive of both the spec and the paper.
Thanks, Ian.
Thanks, Ian. Right, are members happy to approve this proposal? Tricia?
Absolutely. Having looked after patients with this condition, it is so important that we have seamless pathways. What I would say, though, is I think this leads me to consider there must be other pathways that we need to bring together based on empirical evidence. So we need to have a rolling programme where we can review those and think about how we provide a consistent offer to our patients within Norfolk and Waveney.
Thanks, Tricia. So I think you have the approval, Gemma. Many thanks for bringing this note to us and the work you and the team have been doing. Thanks.
Lovely. Thank you.
We go to item 11. First off, delivery group reports. So I think we start with you, Shepherd, and then Fiona will cater on the dental side. But first, over to you, Shepherd.
Thank you, Hein. So this report is for noting and to keep our members informed of the discussions that took place at the delivery group meeting. The 2 meetings that were held on the 14th of January and also the 11th of February. The meetings were both well attended with good discussions, and both meetings were declared quorate. All the items that were discussed for both meetings are well set out in the paper, but I'm going to just make 2 comments on the approvals that were made. I'm really pleased that we received approval for the boundary change for PAC surgery and flag surgery in Great Yarmouth and Waveney. And the 3rd point is around the approval for recommissioning of leases that are due to expire at the end of this financial year as enhanced services. So locally commissioned services being commissioned as enhanced services at the end of this financial year. I don't have any other kind of significant issues to raise. I think they're all covered in the report.
Thanks, Shepherd, and good to see they're well attended, these delivery group meetings. Any questions or comments for Shepherd on this report? No, thanks. very, very much, Shepherd. Fiona, can I hand over to you, please?
Yeah, thank you. I'll cover the dental development group just very quickly. This group is our informal forum for sharing ideas around our dental commissioning plans and proposals. And this report summarises the last meeting. But I would like to say, as it's coming to the end of the year, how very grateful we are to all the clinicians and stakeholders who participated in that group over the past year and helped to inform our plans. And that group will continue into next year as well. And then moving on to Dental Services Delivery Group. This report summarises the most recent 2 meetings that have taken place in January and February. Both meetings were fully quorate. If I can draw attention to one of the decisions that was made around the referral management system, you will note in there that we've highlighted that in reaching this decision to extend the contract, and this is a electronic system for oral surgery referrals going into level 2 or level 3 services, that some concerns were raised by clinical colleagues around how this service actually operates. We have done an audit as part of the information to inform the decision, but we are taking forward those concerns into next year. And when we look at what the alternatives might be, then obviously that will play an important part in informing what we might do next. The other part of the report, we've been asked to bring to you a report on progress on the long-term dental plan, and that's provided as Appendix 8A to this report. I think it's fair to say that some of the plans that we laid out last May have taken time to progress, but that's because we wanted to make sure that the new pathways that we've been introducing work successfully, are supported by clinical engagement and key stakeholders, and that's why they've taken longer than perhaps we envisaged at the beginning to take effect. But I'm pleased to report that we are now launching the Child Focused Dental Practice pathway this month, and the shared care pathway in the early part of next year. I also draw attention to the unscheduled care, so urgent treatment appointments. You can see there from the graph that the number of appointments is increasing, and in fact for January 25 we're now up to 2,500 appointments per month, and that trend continues to go up. This service will continue into next year, and of course we've now received the planning guidance from the national team as to what the expectations are of us for next year, and we're working with local providers. So I just wanted to highlight those and also the new patients. So the number of new patients that are being seen, so when comparing the period April to January 23, 24 and 24, 25, we've seen more than 4,000 more new patients in the previous year. So that is really good news, but it's small steps. And we'll be bringing our plans and also outcome measures to the Primary Care Committee in May. I'm happy to take any questions.
Thank you very much, Fiona. Thanks for allowing us to peek what we'll see in May coming to committee. Looking forward to that. I like to need the chart on new patients. Very encouraging steps we're making. So thanks for sharing that. I'll open up for questions and comments. Nick.
Hein, can I just dampen your enthusiasm about new patients and so on, because the government have decided to dump the new patient premium. In other words, that is something that was introduced in the development plan that the previous administration introduced to try and encourage new patients to come through the door, and dentists were paid an additional fee for a new patient. They've actually, the current administration has stopped that. So there won't be that incentive going forward. Whether that will reduce the number of new patients being seen, I suppose we will have to wait. The mobile dental van, I think, again, was part of the development plan that the last administration had, and they put a lot of store by that. But actually, I think the new administration has decided that maybe dental vans aren't the panacea to all ills. And quite rightly, I think they've decided to use that, what was going to be an enormous amount of money in other ways, rather than pay for 12 dental vans around the country. So just that's probably an update on the long-term plan.
Yeah. Thanks, Nick. Any other questions, comments? Tricia.
I was really heartened to see the entry around child-focused dental practices, because when we look at our paediatric data, one of the biggest issues that we see is around extraction. And so hopefully by getting more capacity in that space, we should see better outcomes for children. But when do we think we'll have enough coverage? So I know it's 6 practices, but Fiona, in your plan, what do you think good looks like with regards to coverage?
So we were very keen that we started small. This is a collaborative working partnership with the community dental services. And we wanted to make sure that the pathway works well and works successfully before we seek to expand it. We're currently working with the community dental service to really understand the data and how much demand there will actually be. The ironic part of it is that as we improve access generally, we will actually improve the number of children who may need to go through this pathway. So to start with, we may not actually see a reduction in children needing GA, general anaesthetics in secondary care, but obviously that's over the long-term aim. And we're being very well supported by the ICB's research and evaluation team in looking at how we monitor this programme and evaluate it with both provider and patient and key stakeholder feedback over the next 18 months.
Thank you.
Thanks, Tricia. Thanks, Fiona. Nick?
Sorry, if you just mind me coming back in again, Hein. Can I also draw attention and really thank Fiona and the team for the work that she's been doing, or they've been doing, on shared care pathway. For your information, the shared care pathway is really to help those patients who may be struggling to find a dentist, but have been told by a consultant that they must have their teeth and have their oral health identified and sorted out so that they're dentally fit before they can undertake whatever course of treatment it is that they're going to have done, in many cases, a course of cancer treatment. And you can probably appreciate, for those patients who are struggling to find a dentist, but have been told by a consultant that you must be dentally fit before you can start treatment, and have the sort of Damocles hanging over their heads about the diagnosis of cancer, it can be an extremely distressing period of time. And so for this particular initiative to have been picked up and pushed forwards, I think is a real, really welcome move for those patients who are really struggling at a most difficult time in their life. So I would certainly give applause to the team for that initiative. It's going to work out to be very, very successful for those patients who are struggling at a difficult time in their life. So well done.
Thank you, Nick, for recognizing that. And I had heard of it, but you put it in such eloquent way that this is a great initiative for exactly the reasons you mentioned. Thanks for recognizing that. Good. I see no further hands, so many thanks for that update, Fiona. We'll move to item 12, the strategic finance report. James.
Thank you, Hein. Yeah. So as usual, I'll treat the finance update as read, but point out some of the pertinent points and concentrate on the executive summary. So as at month 10, the whole prescribing and primary care directorate is forecast to be £8.9 million overspent, but this is split into 3.4 of that within GP prescribing and 5.5 in primary care, which I'll just go into in a little bit more detail. So firstly, the GP prescribing overspend of £3 million. This variance is predominantly down to the slippage in the original stretch efficiency target. The slippage on those efficiencies has been decreasing in recent months, mainly due to benefits from direct pricing that the ICB has been benefiting from. Moving on, we're also benefiting from some backdated VAT claims for oxygen. This is due to a change in the VAT treatment of oxygen costs, and the ICB has benefited from zero rating of those oxygen invoices. Moving into the primary care variance of 5.5, locally commissioned services has contributed £1.5 million to that overspend. This is due to additional activity within complex dressing scheme and a change in the payment mechanism for that LCS. Further to that, there is some Rs and estates additional spend, the value of 3.5 million though of Rs expenditure, which has since been paid to the ICB within the month 11 position, so that it reduces the overall variance that we're seeing, and then also a further £500,000 of DPC increases, mainly around estates related expenditure. There are other smaller variances within GPIT, optometry, dental, and unidentified efficiencies within the primary care directorate itself. Moving on to efficiencies, as at month 10, the efficiency delivery is now up to 90% of the original target of 14.9 million. Schemes that have been overachieving are the price benefits from Rivaroxaban and Apixaban, plus VAT savings on oxygen costs. And then finally, I was just going to mention what I think we went into earlier in the meeting, just around the 25-26 planning. So the recent allocation uplift guidance gave a figure of 2.57% recurrent increase, equating to £5.8 million for primary medical care. As we said before, this is a lot less than the headline number given in the Secretary of State letter to General Practice dated the 2nd of January, where 7.2% cash growth and 4.8% real terms growth figure was quoted. This has been questioned recently at a national primary care finance call, where NHS England have said that this was an unusual for the figure to be quoted within a Secretary of State letter like that before negotiations were concluded, and that there is the possibility of further allocation revision going forward. So that was all I was going to point out from the report, if there are any questions at all.
Thank you very much, James, and thanks for entertaining my detailed questions offline.
Not a problem.
I had a question, and maybe we need to join other colleagues on the line on section 5, the LCS activity tracker. So two things that drew my attention is lower expenditure than budget on care homes, and on the opposite side an increased expenditure on PSA, and I can think of reasons why that is, but is there anyone closer to the LCS activity who would have a reason, or otherwise we take it away as an action? Shepard, you want to have a go?
Yeah, thank you, Hein. We're in the process of reviewing our activities, so I would rather take that away and bring it back at some point.
Yeah, maybe we can log it as an action. Could have some context. Maybe do it on the back of the total year activity. So thanks, Tricia.
So the reason why I joined late today was because I was at the Norfolk and Waveney ICB Advanced Practitioner Conference So we're blessed in that we've got nearly 200 advanced practitioners working in primary care across Norfolk and Waveney, and they came together for the first meeting today. And one of the areas they were talking about was PSA. And what they were saying is that there's a great variability in the way that the screening is undertaken. And it's an opportunity for us to think about standardisation and making sure that the right people are getting screened, etc. So I'd really welcome a conversation with Sadie or one of the team about that going forward, and to think about how we work with our colleagues in primary care, make sure that we're applying the right framework for screening in this area, which is all pertinent because screening and immunisations are becoming down to the ICB as of next year. So it's something that we really need to make sure is in the best place it can be for our residents.
I could hear most of what you said, Tricia, but I can't get the full sound quality on my side. So maybe it's on my side or with your headset, but I got the gist of it, and you invite colleagues from the primary care team to sort of liaise with you on some of the LCS activity. Good, so we'll log that as an action point. Any other questions on the pack from James? No, many thanks, James, for that. We move to item 13, Pharmaceutical Service Regulation Committee. Greg, I think you will introduce that.
Yeah, thanks very much, Hein. So with reference to the paper that's attached, this is for noting purposes only, so I will take the paper as read just for some additional context to it. So the paper is prepared externally by members of the Herts and West Essex Pharmacy and Optometry team. PSRC is hosted and chaired by Herts and West Essex NHS Integrated Care Board, and they work on behalf of all 6 of the ICBs to make the decisions as part of the PSRC under the Pharmacy Regulation Act. So just to draw attention to the various sections that are on here. So we have the market entry section, which details those applications that have been made and determined at PSRC during the time period, which is October to December of last year. There is also the market entry applications that are currently under appeal. So it just details the 3 of those that are currently going through the appeal processes. And also we have the fitness decisions with regards to changes of ownership, changes of directors, and changes of superintendent that have been made as well. There is due to some changes in the regulations, we'll now find that there are fitness decisions that are going to be made outside of the meeting, which is due to a change in regulations around the necessity for references for change of ownership and change of fitness decisions. So we can expect to see those expanding over the next few reports, which has meant that we can spend more time in the meeting discussing the other matters, which has actually been really beneficial. And just to draw highlight to the one application that was delayed and fell outside of the regulatory timescales within those 3 months. So the rest of the paper is for noting, and that just draws highlights to the decisions made for the committee.
Thank you very much, Greg. Any questions to Greg on this note? No, many thanks, Greg, for the update.
Thanks, Hein.
We move to item 14. Some changes proposed to our terms of reference. And Fiona, I think you will introduce this.
Thank you. So the committee are asked to approve the minor changes which are set out in the paper and recommend approval to the board. There are 3 very minor changes, one to reflect the local authority representation so that they can nominate an appropriate individual to attend, and some minor changes in section 6.1 to highlight the oversight and assurance role of the committee, and also to make specific reference to Pharmacy First.
Yep. If you said minor changes, so is the committee happy to approve those, and then they will go to ICB board for final approval. I see no great dissent, so I consider that approved. Many thanks. That takes us to any other business. First, questions from the public. We didn't receive questions in writing, but I'm conscious we have several members of the public on the call. So let me check whether there are questions from the public at this point. If so, please raise your hand. Okay, any other business from anyone, members or attendants of committee? Good, then that concludes part 1. For those joining part 2, there's a separate link. I suggest we take a 10-minute break, reconvene 2:45. See you then. Thank you for joining.